A dilated pupil in a patient with a brain tumor usually is a marker of mass effect and uncal herniation. We present a case of glioblastoma where the differential of the cause of the third nerve palsy is less clear. Mr. SS, a 50-year-old man, was brought with a history of progressive worsening of sensorium. He was unresponsive when he reached us. On examination, the right pupil was dilated and not reacting. In the past history, there was a history of TIA for which he was on dual antiplatelets. He was intubated in casualty. A CT brain which was taken showed massive right hemispheric edema with a midline shift of 12 millimeters. In the presence of a dilated pupil and a midline shift, a diagnosis of hemispheric edema, possibly of ischemic etiology, was entertained, and a decompressive cranectomy was done within a few hours of admission. This is a CT after the decompressive cranectomy, showing that the edema is not suggestive of a stroke, and a mass lesion was suspected. A contrast MRI was then done, which showed a right temporal lobe tumor. Please note the infiltrates in the sylvian fissure and in the prepontine cistern. Another axial cut from the same MRI picture showing enhancement around the sylvian fissure, and you can also see a secondary nodule in the interhemispheric fissure adjacent to the left frontal lobe. Postoperatively now, the edema is less. However, the third nerve palsy has been progressive. Initially, it was just a dilated pupil, and later it has progressed on to a complete palsy of third nerve, along with ptosis. Please note ptosis, a dilated pupil on the right, and external deviation of the right eye. In this patient, the dilated pupil and the complete third nerve palsy is in all probability due to the subarachnoid spread of the tumor, resulting in an infiltration of the right-sided third nerve. It is also possible that the TIA the patient presented initially with was because of the cisternal involvement and involvement of the MCA in the sylvian fissure, which resulted in a transient spasm and TIA.